Hello everyone, I'm Dr. Shalin Vinayak from Nairobi, Kenya. I hope wherever you're watching this from that you're all keeping safe and well, and that yourselves, your families, your clinical practices have safely and successfully made the transition to this crazy new normal that we're facing in our profession and in our lives in general. I'm here to speak about a topic that's particularly fascinating to me, and that's digital implantology, how I use these digital technologies in my day-to-day practice, and in keeping with our MINEC theme for the month, how these digital technologies can help minimize chair time and help limit the spread of any potential coronavirus during these challenging times. So, a brief introduction as to who I am. I did my implant training at New York University. This was the 2-year full-time postgraduate education. I've been a MINEC Knight since 2018, and I'm a diplomate of the ICOI, member of the Faculty of Dentistry at the Royal College of Surgeons of Ireland, a fellow with the International College of Dentists, and finally an associate editor for the Online Journal of Dentistry and Oral Health. So let's get straight into it. And this is a case that a patient who presented to us about 6 or 7 months ago, well before the coronavirus pandemic had taken shape. And as you can see from his panoramic radiograph, he's had a lot of work done and needs a lot of work done. He's been through a particularly challenging time in his life, and his finances are not in the best shape right now. Which is why his previous work had stopped from the previous dentist. And he presented to us with a little bit of discomfort on his upper right, pain while chewing, and the bridge extending from the second molar to the second premolar first premolar was a bit loose. So upon examination, we identified several areas that needed to be addressed here, the upper right being the obvious one. We can also see from the radiograph some periapical pathologies on his maxillary central incisors, as well as generalized bone loss. His previously done implants, these are many years old now. The restorations were breaking down now. We have chipped ceramic and open contacts. So he really needed a lot done. But with his limited finances, we had to identify what had to be addressed most urgently and start with that. So the first thing we wanted to work on was the upper right with that failing bridge and a couple of teeth with periapical infections. Those teeth had a poor or hopeless prognosis at this point and needed to be replaced with dental implants. I wanted to start with that because it was very important that we maintain bilateral posterior contacts to prevent further damage to his anterior teeth. And whenever his finances allow, we can approach other issues that had to be addressed. So this was the clinical situation, having removed the posterior right bridge. And we can see the upper central incisors here. There's a bit of erythema around the gingiva, and those were the teeth with the periapical pathologies. Because we were starting with the posterior maxillary right quadrant, we started off just with the root canals on these two teeth to keep the infection at bay and prevent it from getting any worse. As we can see here, we placed 3 implants on the upper right, and we had to do a sinus lift for him as well. This needed about 5 or 6 months of healing before these were restored. And we did eventually restore those 3 implants before we had to adjust our clinical practice to the coronavirus pandemic. Now we can already see over the course of these 5 or 6 months slight resolution of the apical pathology at the 2 maxillary central incisor apices. And unfortunately, we had to stop all elective procedures until we could readjust our clinical protocols at our place. So the next time I saw the patient was a couple of months ago when he presented with complete fracture of his maxillary centrals. Now he came in with the crowns, and these were splintered crowns in his hand, and we could see clearly inside those crowns a good large chunk of the abutment tooth was stuck in both of those. These teeth had sheared right off, just a couple of millimeters above the gingiva in some places, and we had to assess them individually to see what we could salvage from this. Now, this is the radiograph of the site. And if we look at the bone levels interproximally, we can see that this fracture, particularly on tooth 2-1, his upper left central incisor, is very close to the crest of the bone in a couple of places. And this made it challenging from a restorative standpoint because there's an insufficient ferrule there. And I personally do not recommend lightly crown lengthening and trying to gain additional tooth structure, especially in the aesthetic zone. That would create quite an asymmetry between the two central incisors. It also happened that tooth number 1-1, the other central incisor, you can see how dark it is here. This presented with grade 2 mobility, and now that the patient was without his splinted crowns, we could assess them individually. And this had a periapical lesion combined with a periodontal lesion that was causing this mobility. So very poor prognosis on both of his two teeth. And we opted to replace them with dental implants instead of trying to salvage these ones here. Our treatment plan, as I said, was to extract 1-1 and 2-1 and to replace them with dental implants. And this would be done immediately if possible. Now, why did I advocate the placement of dental implants after the onset of this coronavirus pandemic? Well, I'm trying to recommend long-term therapy for the patients. This coronavirus looks like it's here to stay with us for quite a while, and there's only so much heroic dentistry I can do to these teeth to keep them going. And I'm more comfortable doing a long-term treatment plan because I'm then in control over when I would see him next, when his visits are. Trying to salvage something out of these two teeth would most likely result in emergencies of crowns breaking, crowns falling off at unprecedented times, and we may have had to see this patient on numerous occasions that could have been avoided otherwise. So in addition to providing a long-term treatment solution to this patient, we also want to minimize the number of visits, keep each visit as short as possible, as efficient as possible really, to prevent unnecessary contact between the patient and our staff. And finally, we want to keep this treatment simple, as low risk as possible, to avoid any unforeseen complications that may arise over the healing period or over the treatment period, again with the goal of minimizing the number of visits. So coming to digital implantology, there's really 4 facets to the use of digital technologies in implantology. We have the first one being acquisition or scanning. We then have planning, where you do your implant simulations, and we finish this with CAD and CAM. Now this applies both to the surgical side of implantology, where you're planning your cases for the fabrication of surgical guides, as well as from a restorative standpoint. You still go through these same 4 steps to restore your implant cases digitally. And I'm going to show you this case from start to finish, how we planned it surgically and restoratively as well, using all the digital technologies available to us. So we start with an intraoral scan of the patient. Now, when compared to conventional impressions, an intraoral scan, personally in my hands, is much quicker than taking, say, a PVS or an Improgum impression. It's much more tolerable for the patient, and for the purposes of planning or restoring implant cases, it's certainly accurate enough, and it gets the job done. So during this initial consultation with the patient, we start with the intraoral scan. You can see that paying a lot of attention to the site of the fractured teeth. We want to capture as much of the surrounding gingiva at those sites as possible, and I'll show you why in subsequent slides. We want to try and capture the contact points nicely on the adjacent teeth, and enough of the occlusal and facial and palatal surfaces, at least of 1 or 2 teeth adjacent to where the tooth is fractured, because those will be the teeth that will eventually seat our guide. Now if you look at the bar at the top with the little square icons, you'll see that we also scanned the opposing arch, the mandible, and we took a bite scan as well, because we really need all this information to come up with a proper digital wax up here, taking into account the patient's occlusion as well as relationship to adjacent and opposing teeth. So this was the final intraoral scan we had. Again, I'll emphasize that we spend a lot of time capturing the relevant areas, and this great thing with digital, you can focus on the areas that matter most with that impression. In this case was the site of the fractured teeth, palatal and facial to those teeth as well as capturing all the surfaces of the teeth that would hold the guide, which would be 2 or even 3 teeth on either side of these ones which are fractured. Posterior to that, if you get a couple of holes or gaps in the scan, as you can see here, you really don't have to spend the extra time going to fill those in, because you can get the job done just by getting the relevant information. So having taken an intraoral scan of the patient with our handheld scanner, we then take a CBCT of the patient. Now, when taking a CBCT for the purposes of digital planning, as opposed to conventional planning, you want to take note of a couple of things. Firstly, you want to separate the maxillary and mandibular teeth. This is achieved by either placing some rolls of cotton around his molars for him to bite on, or placing some gauze between the arches. This makes it clearer when reviewing the scan data without any crisscrossing between the two arches. It also reduces scatter by keeping that gap or that section of air between the two arches. So in this case, the patient has a lot of previous restorations, implants, root canals, which would generate a lot of scatter. And to try and minimize that and allow us to see as clearly as we can the underlying bone, it helps to separate the arches. The next thing you want to take note of is that when doing digital planning, you do not need to create a scan template for the patient to wear when taking a scan. We scan the patient just the way he is, with fractured or missing teeth, because we know that we're going to go and do a digital wax up later, and I'd rather not have the added interference caused by these scan templates. Now in this case, we had the CBCT available to us from a couple of months previously when we were planning his posterior right maxillary area, so we did not expose him to additional radiation. We did not want him going into that room unnecessarily, again to minimize the risk and limit the contact of the patient with the various parts of the clinic. So we used our previous scan data, which had the benefit of giving us the prosthetic tooth as well. Having taken a scan, we now have the CBCT data of the patient, and we also have the intraoral scan that was taken of the in the mouth. We can now take these two data sets into our independent planning software and merge the two together. Now, there's several different planning softwares available. R2Gate, the one offered by Megagen, works fantastic. It's got some features which are unique to it, such as the ability to view your scan data in color. Now, I'm not going to go too much into detail of how R2Gate works here. I'm simply going to point out various things to look out for when planning a case digitally. These are generic factors. Regardless of which software you're going to use, you're going to look for these same pointers over here. And I know that there's several other great speakers lined up in the month of July, and from the previous lecture series as well, who went into great detail about R2Gate. And just to avoid a duplication of that information, I'll refer to their lectures for a more detailed review of the R2Gate software itself. So coming back to our case, we merge our two softwares together, and most softwares can do this automatically just by identifying a couple of key points. It helps to have a CBCT that's been exposed with minimal scatter and a clear intraoral scan to get a very accurate alignment. And this can be adjusted and tweaked manually if need be. In most times, for me, the automatic alignment feature works best. So with our two data sets, the CBCT DICOM data and the intraoral scan file, having merged them, we can now plan the position of our implants. Now, I mentioned to you that we do not use any scan templates when taking our CBCTs because we rely on the digital wax-ups based off our intraoral scans. In this case, that was not necessary because we had the pre-extraction CBCT of the patient with his previous crowns, which he was quite happy with the look of, so we stuck with that. But if we didn't have that, we would have either done a digital wax-up or scanned him with a prosthesis, something like a denture in place, to give us an indication as to where to plan our implants. So a closer view of this prosthetically guided implant simulation. There's different things you want to look out for here. And just first and foremost, I want to show you how an intraoral scan can help you simply with your planning. Even if you're not going to go ahead and make a guide for this case, having an intraoral scan and merging that data with your CBCT still gives a lot more information than just the CBCT alone. If you look at the two images on the screen for teeth positions 1-1 and 2-1, the green outline you can see, that represents our intraoral scan data, which really shows us our soft tissue profile as well as the outline of the fractured tooth. Now, the soft tissue is something that you cannot accurately see from a regular CBCT. Having this intraoral scan data can show us things like the depth of the vestibule, as you can see on the image on the right. We know how deep that vestibule is in relation to the crest of the bone, firstly, in relation to the implant platform, and in relation to our restorative margin. Now, that you can tell from this image here if the patient needs a free gingival graft or connective tissue graft to increase the zone of attached tissue or not. This is information that a CBCT alone would not give us. Secondly, you can see the thickness of soft tissue, both buccally and palatally. Now, again, coming to the green outline at the two sites, in your planning software, you can measure exactly what is the distance between that outline or the outermost portion of the soft tissue and the outermost part of your buccal plate of bone, and you know exactly how thick the tissue is. Again, giving you further information that a CBCT alone cannot give you. And this helps in the planning phase as well. It lets you know, again, if you need a soft tissue graft at the time of implant placement, in cases where you're going to do the implant in a flapless manner, do you need to take into consideration a soft tissue graft at time of placement? Should you raise a flap to allow for a second stage procedure where you want to roll the tissues, or is it thick enough to begin with? So having this additional information, the ability to view the soft tissue profile in relation to the underlying bone, that's a huge plus in terms of planning. The next piece of information we have available to us is the location of the crest of bone in relation to the soft tissues at the crest, and we can identify the vertical thickness of the tissues. Now, studies from several authors, in particular Linkevicius and his group, have shown that you need a certain amount of tissues, not just horizontal to the implant, not just buccal, but in a vertical manner as well, to limit any future changes. Now, with combining these two informations, you have that information up front. You don't have to numb up the patient and do a bone sounding to determine that depth. I already spoke about the zone of keratinized tissue in relation to our implant platform. Here's where Artigate really has a big advantage over other softwares, in that you can go into what's called the digital eye mode, and instead of viewing a CBCT in monochrome, you can now convert it into a huge spectrum of colors that makes it a lot easier to identify dense bone from soft or poor quality bone, and it lets you predict the level of stability you could get out of that placement, which really helps you plan your cases and know in advance if you're going to load this implant immediately or not. And finally, having this soft tissue profile or the wax up or prosthetic outline allows you to make an informed decision whether this case is going to be screwed or cemented, and to know that beforehand going into the case, as opposed to figuring it out at the time of impression taking. So having planned our case and hoping to do a couple of immediate implants for this patient after extraction, we now go into fabrication or design of our surgical guides. Now, just before I go into the steps involved in designing a guide, just want to establish what do we mean when we talk about guided surgery. Well, when we use the term guided surgery, we're referring to the definition proposed by Thomas et al. In 2014, where they use a static or immobile surgical template to guide the placement of our implants based on the pre-planned location of those implants from the planning software. This pre-planned location is prosthetically driven, not purely based on where the bone is available, to kind of guarantee that we're as accurate and as true to our planning or simulation as possible. And D'Souza et al. Showed that gave a great classification here as to what are the different type of surgical guides available, which just helps us plan the case, assess the level of difficulty in terms of doing this case digitally and guided. So the first classification is by extent of surgical restriction. And what I mean by that is how much does your guide limit the movement of the drills through that guide. You can have cases done fully guided, which is what I'm going to show you with this particular case using the R2 gate surgical kit. In a fully guided case, all your drills, every single drill from your initial drill to the final drill, and sometimes even the implant placement itself, go through the guide. The guide limits any movement of your drill other than what, so it keeps you true to what the guide allows. And the fully guided cases allow you to keep your depth, angulation, even the implant hex position as per the planning software. Next, we have semi-limiting guides. In a semi-limiting guide, the difference between that and a fully guided case is that not all your drills will go through the guide. A lot of people use this purely for the initial drills, just the 2mm twist drill, and then they take the guide out and do the rest free-handed. Now, the third case is non-limiting, or the conventional approach, where you have a preoperative wax up, you'd make an Essex or a suck down over that, create a little hole yourself showing the center of the occlusal aspect, but that type of guide does not limit any deviation in your drill. So it requires a lot of operator experience and a lot of attention to detail to get it done accurately. As much as possible, I try and do all my cases fully guided and only settle for option number 2 or option number 3 if a fully guided case is not possible. And that would be perhaps if we cannot get accurate CBCT for a patient, either from too much scatter, or I've had a patient with Parkinson's who just couldn't hold still when going in the machine and we couldn't get an accurate CBCT there. In those kind of cases, you don't want to limit yourself to just what the guide allows. You want to raise a flap, you want to see what's going on underneath that and take charge of the case, and that's where you may resort to a non-limiting or a semi-limiting approach. Other times I've seen practitioners and colleagues using semi-limiting guides or guides purely for the pilot hole. We see that quite commonly when a dentist does not have access to a fully guided kit. So they would perhaps request for their guide to be designed purely to allow the first drill, the 2mm twist drill, to go through the guide, and then they put the guide away and all the wider drills will be done free-handed. So it still helps, but I try and keep to a fully guided approach whenever possible. The next classification here is what is your guide going to be held by? What is supporting your guide and keeping it held down in place? First, we have teeth. The guide can be supported by soft tissues for perhaps edentulous cases, or a guide can be supported by the bone through the use of bone screws, bone supporting screws, and that's typically done by in cases where you're doing full mouth rehabilitation and you get segmented guides. You get the initial base of the guide that's screwed into the bone, and you get stackable or clickable guides that settle on top of that. Now, in terms of difficulty, surgical difficulty, teeth supported guides are the easiest because it's a reproducible position every time and you're not having to look for bone screws and things like that. So teeth supported are the easiest. Soft tissue, you can't always guarantee the seating position of your guide on soft tissue. The nature of the soft tissue is that it's displaceable. It doesn't provide 100% support the way a hard structure such as teeth does, and so that makes it more difficult and less reliable than the teeth supported guide. And then finally, in terms of the most difficulty in terms of planning, we have the bone supported guides, because these guides are typically in multiple pieces. You get the part that's attached to the bone and different pieces that go on top of that, and it requires a great understanding in the use of these planning softwares. So in this case, we're doing a fully guided approach using a guide supported by the teeth. Having identified the type of surgical guide we want to do here and having simulated our implants, placed them virtually in the positions we want them, we can now go ahead and design our surgical guide. Now, the basic principles of guide design apply to all softwares, whether using R2Gate or any other software available. Things you want to look out for. Firstly, the guide sleeve for a fully guided protocol. Make sure that it's compatible with the guided kit you're going to use. In this case, I'm using the R2 gate guided kit, which has a fixed diameter of the guide sleeves attached to the drills. So we select the appropriate sleeve for those for the guided kit we're using. The next factor you want to look out for is try and keep your guide's teeth supported wherever possible for ease of use and for accuracy in terms of seating it in a fixed position every time. You want to try and extend this to at least 2, if not 3 teeth on either side of the edentulous space for maximum accuracy. So that's a design aspect that you want to take into account. And finally, you'll notice that when looking at this guide from the occlusal aspect, it has a couple of cutouts on it. I'll point out what those are for in subsequent slides. So this was our final design of the guide, based around the prosthetically planned implant positions. This was designed to extend to 2 to 3 teeth on either side of the edentulous gap. A picture of the guide, a close-up here. This picture was taken after the surgery, hence the reason why there's blood on the guide. But just to show you what the guide looks like in its final form. And we go straight into the surgery now. So we extracted the 2 teeth as atraumatically as possible using periotomes. Tooth number 2-1, as I mentioned earlier, was already mobile and really didn't take much effort. 2-1 was actually held firm, and with very little ferrule, we had to be very delicate in terms of how we approached it and how we extracted it. These are the teeth that came out. We can see the extent of infection that was involved around tooth number 1-1, as well as the shorter ferrule on 2-1. There really wasn't much structure there to try and fabricate a new crown on. And we examined the site intraorally. Doing the case guided or not, you want to verify, has the situation changed from the time you did your CBCT? Has the extraction caused any unwanted circumstances, such as a fracture of the buccal plate? Is your bone crest where you had identified it on the CBCT? So you just get the print to each one, verify the position of the buccal crest, check for any dehiscences or fenestrations all the way down. You want to get a curette in there and make sure there's no granulation tissue left behind. Make sure you're down to good sound bone before we proceed. Now, I know that there's other lectures coming up where some great clinicians are going to focus purely on immediate implantology. These 2 implants were done in an immediate manner because the situation allowed for it. And I hope we don't have too much overlap of information between all of the speakers. So having verified the integrity of the extraction sockets, that they will still allow for an immediate placement, we now insert our guide into our patient's mouth. This has been sterile packed up until now. This is now when we open it up, when we know that we're proceeding with our implant placement. And we place our guide down and make sure this is fully seated. That's probably the most important step here, because if you get your guide in the wrong place, if it doesn't go down all the way, your errors just increase exponentially from there. So coming back to the 2 windows that I pointed out earlier, you can see them here highlighted in blue. These little cutouts that we designed into our guide, those allow you to see that the guide is rested completely against the tooth surface, that there's no gap between the 2 surfaces over there. And this lets you know that yes, the guide is fully seated over here. Another thing you'll notice with this guide, looking at it from the occlusal aspect, there are no metal sleeves here. Most guides you see in cases people post include metal sleeves where your implants are going to go. Now that's really the beautiful thing with the R2 gate surgical kits. They have the sleeves not in the guide but in the drill itself, in the shank of the drill, and this makes it very easy to produce these guides chairside. I've got my own 3D printer, and you just print this, trim on any sharp edges, and your guide is ready. You don't have to cement any metal sleeves into there, and it takes away one bit of error, because there's usually a tolerance between the sleeve and the guide to allow that sleeve to go in. It's just the nature of what it is. In this case, you're working directly with the guide as it is. As I mentioned, this is the R2 gate surgical kit. This particular kit I have is for the AnyRid system. However, I know that they make this for all the different systems in the Megagen family, as well as for all the other major implant manufacturers out there, and the universal kit as well. So those of you watching this, even if you're not placing any Megagen implants, this is a great kit to use for guided surgery, having the sleeves built into the drills. You can see that in all the different things here. So regardless of the implant system you're using, you can adapt this kit into your workflow, and it works really well for that. So we create our osteotomy through the surgical guide. The implants we had planned to place here were 3.5 millimeter in diameter and 13 millimeter length. Now, to place the 3.5 millimeter long AnyReg implant, you only need a couple of drills, working with a core diameter of 2.8. It's just your 2 millimeter twist, and I normally drill up to at least what the core diameter in this case was 2.8. So just 2 drills through the guide. Doesn't take long. The guide ensures that you're not moving around too much and correcting angulations. Again, in keeping with your chair time to a minimum, keeping the appointment short. The guide really helps with that. We placed our implants again through the guide, fully guided approach, using the implant carrier found in our AutoGate kit. The technique I use here when I'm doing immediate implants is the dual zone approach proposed by Dennis Tarnow and his team several years ago. So I like to, once I've verified the implants are in the positions we want them, roughly 0.5 to 1 millimeter below the buccal crest of bone, I then take a particulate graft. In this case it was a xenograft, and I fill all the gaps around the implant. Usually the biggest gap is on the buccal aspect, so that's where we start with first, and we make sure we don't leave any voids around this. There's many schools of thought on that. Some people don't graft the gap. I personally do it in sticking with this protocol that works very well for me. Now, those of you who are going to use the dual zone approach, it's very important to keep cover screws or narrow healing abutments over your implants at this time, because the last thing you want is for these bone chips to get embedded into your implant and to only realize that once you put the bone graft in there. So we graft the gap between the implant and the buccal aspect. We then swap out these cover screws for healing abutments. Now, I just use regular titanium healing abutments, and we pack a little more bone just before putting the healing abutment in to actually be in the soft tissue area, to push out between the healing abutment and the tissues circumferentially around the implant. This is our radiograph immediately after the surgery. Very important to take this radiograph to confirm that your healing abutments are seated, that there's no bone chips impinging it, or bone for that matter, interproximal bone preventing your healing abutments from seating. Coming back to the discussion of the type of healing abutment I used, I tend to use the Megagen stock healing abutments, the titanium healing abutments, wherever possible, as opposed to a customized healing abutment or a provisional restoration. And the reason for that is their healing abutments, as you can see in the x-ray, are relatively anatomic. They have a good emergence profile to them. They're not just cylindrical like some other implants I've used in the past. So you still get a decent emergence profile out of them. Yet when compared to a custom healing abutment or even a chairside provisional, it's very quick and easy to use. It keeps your surgery quick. It takes you seconds to put a healing abutment onto that implant once you're finished with the grafting. When you're working with custom healing abutments or chairside immediate provisionals, it takes a lot of adjustment, measurements, using a handpiece to trim any excess chairside. And again, we're trying to minimize the use of handpieces to only what's necessary, and putting the titanium healing abutments on just works beautifully for us. It can also be argued that having titanium in contact with your tissues when they're healing is better for the tissues than having acrylic that's usually there with provisionals. And what I notice from cases I've done with customized acrylic healing abutments is that 2 or 3 months later, when we remove that healing abutment, you get a lot more smell, a lot more bleeding coming out in those cases where there's an acrylic in connection with the tissues, as opposed to the titanium, which just heals beautifully around it. So yeah, that's why I use the titanium healing abutments in these cases. Now, the AnyReg implants are known for their ability to give you very good stability, especially in the major cases. And in this case, with 13 millimeter long implants, good bone apical to our extraction sockets, we did get good stability here. I believe the ISQ reading was in the high 60s. I didn't want to load these implants immediately because, firstly, the time it takes to make the chairside provisional, but secondly, I know that when I put a regular titanium healing abutment on, there won't be any problems during the healing phase. If I put a fixed provisional over these implants, the chances of the patient breaking something, chipping something, the provisional perhaps loosening up, increase, and the chances of me having to see the patient unnecessarily before the implants have healed up are much higher than simply putting a normal healing abutment on. So that's how we did it. I gave the patient a denture and sent him home for review in 6 weeks' time. So having the benefit of intraoral scan, digital planning, guided surgery has several advantages from a surgical standpoint. Dean Morton, in his study, pointed out, firstly, the reduced surgical time. That's probably the biggest factor in this, in terms of why I use surgical guides. Remember, there's only one way you can drill when you have a fully guided case, and that's where you've made your prosthetic plan, provided your guide has seated all the way down. So there's no unnecessary correction of your angulation, which typically used to take the longest time for me prior to going into guided surgeries. You know that where you drill will is where the implant is supposed to go. Secondly, the need for x-rays. Now, previously, I would take an x-ray after the initial drill, and if any corrections are needed, I'd take x-rays after each correction to verify I'm in the right place, an x-ray after the final drill, and then an x-ray when the implant goes in. With guided surgery, I know that the drill is going to go in the right place once I've verified that the guide is seated. Now, out of habit, I still take an x-ray after the first 2mm drill goes in, and I take an x-ray after placing the implant to verify the depth of placement. But seldom do I have to correct anything when doing it digitally, and these are purely for documentation purposes at this point. The next thing that Dean Morton pointed out is that when you're doing your cases guided, there's a lot lower risk, a lot lesser risk of invading any vital structures. That's any neurovascular bundles, your sinuses, adjacent teeth for that matter, or adjacent implants, because you're staying as true to your plan as possible. If you plan the case well, remember, guide is only as good as the surgical plan that you created. If you planned it well, the chances are the case is going to go well, and you won't have these unwanted and unforeseen complications of invading these structures that we're trying to keep away from. And finally, as per his article, having a surgical guide makes flapless surgeries very predictable. Now, I personally don't do too much flapless. I think having the benefit of a second stage is really great in terms of optimizing the soft tissue profile, guaranteeing that you have adequate thickness, height of soft tissues around the implant. But when you want to go flapless, it's no longer a blind procedure. You have something guiding the position of your implant. And there's a lot lesser risk of invading through the buccal plate of bone, perhaps, and avoiding those perforations or hitting the adjacent structures. So this is our patient a week later, and the healing looks fantastic at this point. In keeping with the surgical time being so short over here, the case was done in about 20 or 30 minutes. I can't remember exactly. You know that you're going to get less inflammation in the healing period, but also having the titanium highly polished healing abutments, there's very little plaque adherence to them. This is a patient with less than optimal oral hygiene, as you can see from the adjacent teeth, yet on the healing abutments they look perfect. There's nothing adhered to them, and that's the beauty about using the stock titanium healing abutments. They just work so well, at least in my hands. And we see the patient then 6 weeks later, and you can clearly see the dual zone approach we've used here, where there's some bone substitute embedded in the soft tissues. Now, just going off topic slightly and talking in particular about the dual zone approach, when you take off the healing abutment or restoration and you see these bone particles embedded in the soft tissue, it really keeps those tissues firm around the implant. Even if you keep the healing abutment off for a few minutes, there's minimal, if any, collapse of those tissues, and it allows for your impression to capture that emergence profile without any changes, without the need to duplicate the profile of that healing abutment or custom provisional. So that's why it works very well for me with immediate implant cases. Now, I knew that I had full confidence that I would be taking this impression at 6 weeks post-op. That's my experience with any ridge, that at 6 weeks, my ISQ values are in the high 70s or in the 80s. Those implants are healed. There's such a great surface on that. The X-Speed surface with hydroxyapatite and calcium embedded into it really allows for this healing to happen in just a few short weeks. I actually planned to take his impression, and this would have been done digitally, of course. So the steps required to take a digital scan for implants for the purpose of making a restoration, you need 4 scans, as you can see on the screen. And this is just a generic case I've shown you, but the 4 scans you need. The first one is a scan of the implant arch itself without any healing abutments. You want to capture the emergence profile, you want to capture the contact points on the adjacent teeth, and you want to capture the occlusal surface very accurately. From there on, if you can fill out any gaps on the buccal or the lingual to help your lab tech get a clearer picture of what the adjacent teeth look like, and that guides him to making his designs. So once you've captured the emergence profile, you then put your impression coping, or your scan abutment onto the implant. And Megagen, for any ridge, they have 2 different heights of scan abutments. This is screwed on just with a regular hex driver, and you scan that scan abutment. You then take off the scan abutment and scan the opposing arch. And finally, you take a bite scan in occlusion to capture the relationship of the maxillary and mandibular teeth. You then put your healing abutment or provisional restorations back on, and you can design the case with that information. So coming back to our case, before the patient came in, we had anticipated that we were going to take a scan on these implants for the purpose of creating fixed restorations. So we took his initial scan data. This is a scan we had captured at the time of his tooth fracture for the purpose of planning his guide. And in the scanner software, and pretty much every scanner allows this now, you can edit the scan data. So we cut out the region of interest where the teeth were extracted. We also delete the contact points. We keep the rest of the scan as is. So if you remember, in the consultation, we had scanned the implant arch or the maxillary arch, the opposing arch, and the bite. I still have the opposing arch, I still have the bite. All I need to capture really is the implant positions now, and we have the rest of the maxillary arch in situ. So we just copy it and crop out that region of interest. We then seat the patient down, take off his healing abutments, and scan just the area around those implants. Now, if you look at the red box, the flashing box on the top right, you'll see that this scan took just 46 seconds because we had all this information from before. We don't need to duplicate this information and scan the patient again unless it's been a very long time or the patient's situation has changed. He may have chipped a tooth or something. In this case, there were no changes. So we just copy the same scan information. We want to keep this appointment as short as possible, use as few instruments as possible, expose them to as few people as possible. So 46-second scan, we've captured the emergence profile and the contact points of the adjacent teeth. Now, just a word of advice. When scanning the emergence profile around implants, you want to increase your scan depth. This is a setting on intraoral scanners. You want to increase it to as high as it will go. It just helps you capture those deeper areas a little better. It helps you capture these undercuts underneath the contact points a little bit easier and quicker. So 46 seconds, we got our scan of the implant arch. And this is the final scan we can see here. We beautifully captured the emergence profile. We recorded the contact points nicely, and we're ready for the next scan. We insert our scan abutments or scan bodies. And the obvious point here is that I use 2 different lengths of scan bodies. I'll show why in a subsequent slide. I also like to always take an X-ray and confirm the seating of these scan abutments. They're made of this radiopaque material that lets you see very clearly that you've seated this. This is a kind of guarantee, a fail-safe, that the scan you have and that you're sending to your lab technician is accurate. You don't want to send a scan where your scan body isn't seated and that you haven't checked it. So always take a radiograph to verify the seating of your scan bodies. And we go ahead and scan these scan abutments. So they're screwed into our implants, and you're scanning just the area around those scan abutments. The rest of the arch has been scanned already in this first scan I just showed you. Now, a couple of tips here when you're scanning multiple implants. If it's a single implant, it's very easy. Just put your scan abutment in and scan it. When you're doing multiple implants, you want to try and use different length of scan bodies, especially when scanning adjacent implants. You want to create as much of a contrast or difference between the two scan abutments so that your scanner will identify them as two separate sites. It makes your scan quicker, easier. It avoids you having to rescan the same area multiple times. So whenever you have a system that allows for the use of different length scanning scan abutments, use them. The next point is orient them differently. So you're not just using different length of scan abutments, you're also placing them with their hex position in two different areas. So as your scanner passes over them, again, it's created an extra bit of contrast between the two, and it makes it that much easier to scan. And finally, you want to maintain the flat surface. If you look at these scan abutments, they have this flat surface on one side and they're cylindrical everywhere else. You want to maintain that flat surface on either the buccal or the palatal or lingual as much as possible. And the reason we do this is because the easiest surface to scan naturally is the buccal or the palatal without worrying about any undercuts from the interproximal aspect. And it's that flat surface that will allow you or your lab technician to now match the scan body with his digital library. That's where they establish the common features of a scan abutment from. So make sure that your scan captures the entirety of the flat surface. You do not want any gaps or inadequate scan data on that aspect. One final word of advice is use the tallest scan abutment possible. If it's a single implant, use the tallest one available to you that will fit in that particular site. Because again, that flat surface is what the lab techs use to match their cases. The bigger the flat surface you give them, the more data they have to match with. So in multiple cases, you want that variation, but for single implant cases, you want to use the tallest one that fits in that site. So this was the final scan. You can see where I had my hex position. I had both facing outwards, which is the easiest part of the mouth to scan in, but I didn't have them facing exactly buccal. I put some differences or some contrast between the two in terms of rotation for the scanner to pick them up as quickly and efficiently as possible. The bite and the opposing arch had already been scanned before, so I just take off the scan abutments, put the healing abutments back on, and the patient's on his way out within about 5 minutes of him sitting down on the chair. That's the great thing with digital. It's quick, it's efficient. You're not repeating information that you already have from previous impressions. So we can then send this file out to the lab, and another great benefit of using digital is the time between you scanning the case and them receiving it it's instant. It's like sending an email, and in a very short amount of time we have a CAD proposal back that we approve. And there's no sending of any physical models, in particular during these unforeseen times with the COVID-19 going on. If we can minimize what leaves the clinic, even if you disinfect an impression, it's still potentially contaminated, and if we can avoid sending those out to our labs and just use a digital file that we know is clean and safe, it's well and good. So we approve our design at this, and this is the actual milled restoration. In this case, it's a PMMA to give the patient a provisional restoration before we switch over to the final. We get our two restorations back and deliver them to the patient. These are screw-retained restorations. I try and keep all my provisionals, in particular, screw-retained, because if I want to modify that provisional to play around with the emergence profile to optimize it for that particular case, it's just a lot easier getting a screw-retained case in and out, and ensuring that it's seated all the way. If you're trying to bulk out a part of that provisional, sometimes getting a cement retained one to seat with all that tissue pressure can be difficult, so having a screw retained provisional really helps for that. And this is from the frontal aspect. The bleeding you see on the adjacent teeth is because we took the opportunity to give the patient a scaling and polishing while he was here. But this is a case that was planned digitally. surgically placed through a guide, restored digitally as well. And we got a fantastic outcome with Visionals. Our patient is really thrilled with it. And we're giving the tissues a few weeks to mature before we finalize this case. So this is his current status and benefit here. Our final radiograph here shows our tie bases attached to the implants. On how I select my tie bases, I mean, those of you who are going to start out digital, you get so many variations in tie bases. There's different cuff heights, different post heights, different diameters, just like you have with regular stock abutments. And how do we choose it here? Well, firstly, I want my cuff height, my cuff, to be at or above the level of the bone. Now, typically with any ridge implants, and especially when doing an immediate case, you know that your implant platform is going below the crest of the bone by 0.5 millimeter or millimeter. So I select an appropriate cuff height that allows me to keep the titanium base in proximity with the subcrestal tissues, or I basically want titanium against against the surrounding bone, and we'll have the restorative material only in the soft tissue area. The second thing is, with the tie base, your lab tech will mill the restoration separately and attach it with a luting agent of sorts. And in the off chance that there's a slight marginal gap, excess cement perhaps, any irregularity in that surface, I don't want that irregularity to be at the bone level, which is why I select a cuff height that's at or above the level of the bone. The next feature is the diameter of tie base, and I'll select the diameter that's as narrow as possible because I want the restoration to customize my emergence profile. I don't want to get locked into using what a taller tie base gives you as a fixed standpoint in terms of the cuff height. So I want the narrowest diameter of tie base possible so that the restorative material can shape my emergence profile, and that allows me to really customize the case as opposed to using something stock. And the third factor here is the height of the post, or the part that your restoration sticks to, and you want that to be as tall as possible, just because that's the surface in contact with the restoration. That's where the surface area of the luting agent is. Just to guarantee the strength of cementation, the tallest post height possible for that case should be used whenever possible. So those are the three criteria I use when selecting tie bases. Now, that's the current status of our case. We'll restore him in due course, but I just want to touch up a little bit on some more benefits of digital. What does the literature show us in terms of digital versus conventional? Because it's well and good saying that it helps you minimize chair time, but we want to make sure it's accurate. It's no lesser than the conventional means of doing things. So the first benefit here really in terms of scanning versus a conventional impression, and I'm talking about from a restorative standpoint now, is ease of use. Scanning a case is a lot easier to the experienced scanning practitioner compared to taking physical impressions with rigid silicone or polyether impression materials. When taking a conventional impression, you have to block out any excessive undercuts. If it's a case with recession, you have to close those interproximal spaces with wax or some other method. Patients with large tori where it's difficult to seat a tray. Again, these are factors that don't exist in digital. You can scan the entire case regardless of undercuts or mobile teeth for that matter. Moving on to accuracy. Is digital really as accurate as conventional? Well, several studies from Lee et al., Gallucci and his team as well, and several other authors have shown that the accuracy of a well-taken intraoral scan is on par with your conventional impression. And going a step further, your digital scan has a permanent shelf life. There's no loss of dimensional stability with time. It's stored on your computer. And no matter what impression material you use, it will eventually lose a bit of accuracy. Here in Kenya, I personally send a lot of my work out of the country to labs that I've worked with in the past, either in America or in the UAE. And this dimensional stability is a big factor for me. And having the option to go digital without the loss of dimensional stability plays a big part in that. It takes out the gypsum or casting errors, incorrect articulation. Even if you've done everything perfectly, if it's articulated wrong, it's bad. And movement of your lab analog. Those doing closed tray impressions will know that the analog moves a little bit. With digital, that's not a factor. Then time. The time taken to capture or acquire a scan of an arch is much quicker than, again, conventional PVS or polyether for reasons discussed previously. No undercuts to deal with, no setting time to wait for, and you can typically scan arches in a couple of minutes or less. No splinting of multiple impressions here. Another great benefit for those of you doing a lot of long span implant bridges or full arch cases. No blockout, we spoke about that already, and your turnaround time as well is much quicker because the lab gets the work immediately. In terms of patient comfort, that goes without saying. Digital is a lot more bearable for the patients to not have to contend with the pulling forces of removing a rigid impression material from the mouth. I once actually spilt a light body, bright yellow light body silicone on the patient's black sweater and had to take charge of his dry cleaning bill for that. Now, with digital, of course, that's not a factor. Then coming to hygiene, there's no physical models moving around between staff members in the clinic or physical models leaving your clinical practice, going to the lab. It's just cleaner, neater to work with, no trimming of models. And finally, flexibility, which I'll show in the coming slides, where you can scan adjacent implants or multiple implants with a single scan body. Either if you don't have multiple scan bodies or if the situation doesn't allow you to put multiple scan bodies in. So here's a case that I scanned digitally, and we wanted to restore those two implants before removing his braces so that the space doesn't change. Now, it's impossible to get that impression in a rigid material like polyether with the braces or even brackets present. I mean, you can sometimes get away with wax around the brackets, but the chances of debonding a bracket with a rigid impression material are very difficult. Also, ortho teeth tend to have a little bit of mobility to them, and that may also lead to inaccuracies in your contact points. So scanning this case, we didn't have to prepare the patient at all. We could scan it, get the crowns prepared, and deliver them on the day that we were planning to remove the orthodontic appliances without worrying about any potential relapse in the time it takes to make that crown. Here's a case referring to the flexibility where you can scan multiple implants with a single scan abutment. Now, this is a slide sent to me by a colleague. It's not my case, but you can see the angulation of the implants meant that his impression copings in this case were touching intraorally, and he had to trim them and modify them to get them both to fit together. If you're going to restore this case digitally, you can put one scan abutment on, scan that, take it off, put it on the next implant, and just lock out the area where your first scan is, and you can capture both separately. Even if your scan abutments crisscross, it doesn't prevent your lab tech from getting a good match of that scan data, and you don't have to go through the difficulties of trying to modify your impression copings. Now, when we talk about digital dentistry and digital implantology, there's a lot of challenges and myths being thrown around out there. Does it work? Does it cause heat generation? Is there enough space to use these implant drills, which are typically longer than regular drills? So we're going to see if we can debunk some of these myths and show that digital really is not that difficult and can work in most cases. The first thing being Interarch Space. That's probably the biggest question we get when we show a digital case at a presentation or at a forum. People ask, in the posterior area, will your digital drills fit? Can you use a guide? Does it take up too much space intraorally? So let's look at that. And Munira, as well as Van Ashi, Verkusen, and Karim Al-Kholi, they've all shown in their studies how much space you need. Firstly, how tall a guide should be, or a guide sleeve should be, to make sure it's accurate. Now, Al-Kholi in his study last year showed that you need a minimum of 4 millimeters height of a guide sleeve for a fully guided case to be accurate. Anything less than 4 is not accurate. Anything more than 4 is desirable, but it chews into your Interarch space. 4 really is the critical number. Now, traditional guided kits looked something like this, where you had a guide with a metal sleeve. That sleeve has to be 4 millimeters. Then you have these keys that slot into that metal sleeve. and that key has a lip of about 1.5 to 2 millimeters on it. And then you get these ultra long drills that go through that key, and there's a different key for each diameter of drill you go for. So it's quite a cumbersome process, but it also took up a lot of Interarch space. Now, the R2 gate kit does not need keys, it does not need guide sleeves in the guide. You have your so-called built-in guide sleeve in your guided drills themselves. And so you don't have any of these extra roll factors that add to the length of the drill. It's as short as it can be. You also get a kit full of stopper drills, so you don't need a maximum length drill. For every case, you use the shortest drill possible based on the length of the osteotomy you want. Moving on, to place this implant, the 13mm long AnyRidge, you can see the regular gold twist drill, where the 13mm mark is the line coronal, or in this case below the thick black band. And the length of the 13mm drill is roughly the same length as your guided stopper drill of 7mm, as you see on the right. Now, you could always use a 7mm drill if space is limited, which is the same length as your regular drill. Create that initial osteotomy and then switch to the longer drill, and it's easier to insert it. Another workaround that Megagen has created in their AutoGate software is your guides can be designed with this cutout on the guide sleeve on the buckle or the lingual aspect, which allows you to get your guide drill in from a much more apical position. You're not trying to get it around the top of the guide, but you can bring it in from a much lower position. You contract in limited interarch space. The next potential myth is that guides can move while drilling. Well, they can if you're using the traditional type of guided kits, where there's a built-in tolerance between the sleeve and the guide, a further tolerance between the key and the metal sleeve. And you can see here when the drill lifts up, it's moving the whole guide. Well, with R2Gate, there's less things that can go wrong. There's less components. It's a lot more stable. Coming to contamination of the guide, how do you make sure your guide is sterile? Well, advances in 3D printing allow you to print these guides chairside in a material that's FDA approved and can be autoclaved. So if you can autoclave these guides now, you're not just relying on soaking them in chlorhexidine or betadine. You're sure that these are as sterile as your surgical setup is. I also like to print more than one guide for each case. In the rare instance where I may drop this or it gets contaminated during a surgery, I have a separately wrapped and packed autoclaved guide that can be used to finish off the case without reverting to a free approach. The final myth here, heat generation. Do guides increase the temperature? Well, yes, they do, but do they increase it to the critical temperature of 47 degrees for over a minute as identified by Brennemark? No, not if done properly, not if you maximize your irrigation, reduce your drilling speed, keep it to under 1200 RPM as shown by Barak et al. And Dos Santos et al. Use an up and down motion, don't just hold it right in there. I like to refrigerate my coolant, keeping it at roughly 5 degrees before we start the surgery, so that further helps to cool our drills. And just flush out your osteotomy with some saline in between drills to cool things down. Now, the new implant motors that Megagen supply, the Megagen 3 and 3 Pro, come with these handpieces that have dual irrigation systems. You have the normal external irrigation and this second irrigation tube that goes right along the shank of your implant drills. And when you're drilling, even if the external irrigation on the side splashes off the guide, you have this inner one that's going right against your drill, keeping it cool. So it does help, and haven't had a problem with overheating of bone. Finally, operator error, bad scan data. You get bad scan data, you'll get an inaccurate or poorly fitting guide. In this case, this was one of my first guided cases where you can see the error in the scan, the little step that was created from poor merging of the two sides of the jaw. And to compensate for this, we had to just shorten the span of our guide, and the case worked out okay. But you want to minimize these kind of errors as much as possible. So my take-home message would be, firstly, if you're going to use an intraoral scanner, start with prosthetics first, master the art of scanning before you use that scan data for the purpose of planning a case, or use a desktop scanner. Either way, make sure you get good scan data for use with your case. Secondly, a guide is only as good as the virtual plan. Any shortcomings in your implant simulation or implant position from the plan will be translated into the clinical situation, especially in a fully guided approach. So your virtual plan has to be bulletproof. It really has to be done well for the guided case to come out well. Thirdly, a guide is just a tool to improve your surgical efficiency. There are times where guides may not fit. Most errors come at the time of 3D printing chairside. Those of you who are going to do this in-house, you're introducing external factors such as excessive curing of your prints, incorrect autoclave cycles. It's usually errors related to the printing process, not the planning software or the design itself. But sometimes the guide may not fit, and you want to be able to do this case without the guide if it comes to it, or if you drop your guide on the floor for that matter and don't have a spare. You should be able to finish that case free-handed. Don't rely on the guide to be able to do the case with it. Take confirmation x-rays. That's one thing I would say. A lot of guided kits I see don't have x-ray pins, so I actually have added those in myself. I still take confirmation x-rays. It's just good habit, good practice, good documentation to have to make sure you're drilling in the right place and not being completely reliant on the guide. Raise a flap when necessary. Just because you have a guide doesn't mean you have to go flapless. By all means, do a second stage procedure later if you want to play around with the soft tissue profile. Don't limit yourself to only going flapless. And as I said earlier, have a plan B just in case your guide doesn't fit. It's our own fault that it doesn't fit, but you got to be able to finish the case off anyway. With that, this is my little digital setup I have here with my 3D printer, scanner, and curing unit. I thank you very much for your time. I hope this presentation has been helpful to you. I hope there's something you could take home from this that will benefit your clinical practice. Feel free to contact me for any questions on either the email address provided or through my Instagram handle at VP Dentistry. Thank you very much for your time. It's been a pleasure. Thank you, Minek. It's really been an honor.